All right, so chapter 4 talks about documentation. Basically, how do we document patient care reports, what should be in the reports, where they should be in the reports, um, how should you speak in these reports, and those type of things. All right, so the elements of your EPCR um, is the minimum data set. So the data that the DOT recommends um, included on all patient care reports is called your minimum data set. So included in that is a patient information. So the patient's chief complaint, level of consciousness, blood pressure on patients greater than 3 years old, skin perfusion, skin color, temp, condition, pulse rate, respiratory rate, patient demographics. So basically all their vital signs. Um, Administrative information. So people confuse administrative information with um, like addresses or demographic stuff. I'm not so really worried about demographic things. This is more so the time the incident was reported, the time the unit was notified. So basically, how long it took you to care for this patient, how long it took them to get to the hospital, how long did it take you to respond to this call, that type of stuff would be under administrative information. You must maintain at least 2 sets of vitals to establish a trend. You're going to need a patient narrative. So this must be detailed and must include the chief complaint, the patient's history of present illness or mechanism of injury. This is where you can paint a picture of the entire call that you can't put into all those drop down boxes that are normally on the other parts of your PCR. So when you're documenting things, it's good to know the difference between objective and subjective. So objective information is measurable or verifiable, like a pulse rate or a discoloration in a person's eyes. A sign is an objective observation. So you can you can physically see a sign, right? And you can also physically see an object. So these are things that you can see, you can measure, you can touch. Um, Whereas subjective information, just think of a school subject. You can't see math, right? You can't see reading. You can't see history like as an actual thing. You can't measure it. But you know it's there. It's off of what somebody's telling you. So your subjective information is based on an individual's perception. So if they feel lightheaded, if they feel nauseous, I can't see you being nauseous. So that would be subjective finding. However, if you vomit, now that's an objective finding because I can physically see the vomit. Your treatment should be the last part of your minimum data set. So this section should detail in chronological order all treatments administered to the patient, what time they were administered, and the patient's response to these treatments. Right, and this just lists out the minimum data set. Make sure you pay attention to the difference in signs and symptoms and objective and subjective. All right, some examples of medical abbreviations. So a lot of times you'll read in your textbook and it says like you shouldn't use abbreviations because not everybody's going to know what that abbreviation is for. They can commonly be mistaken for other things. It's not really looked at as professional anymore. However, there are some common abbreviations that are, used a lot that mostly everyone knows or you're expected to know. So like NTG would be nitroglycerin, O2 is oxygen, TX would be treatment, GSW is gunshot wound, SOB is shortness of breath, ABD, abdomen, right upper quadrant, left upper quadrant, left lower quadrant. So LLQ, RUQ, those type of things would be common to know. All right, so that's it for chapter 4. Chapter 5 is communication. So everything that you just documented, now you're going to hand off to a higher level of care. So you're either going to hand off to another EMT, you're going to hand off to a nurse, a paramedic, any type of higher level of care that you would be communicating with, even your medical director. This chapter also goes into communication with the patient's family. All right, so what are some advantages of an enhanced 911 system? So an enhanced 911 system provides automatic number identification and automatic location identification, which indicates the exact address and phone number from which the call was made. The base station serves as a dispatch center. The land mobile radio system allows for the dispatch to contact mobile units and portable radios with call information. Repeaters are devices that receive transmissions from a relatively low-powered source, like a portable radio, and then rebroadcast it at another frequency and higher power. Repeaters are located in emergency vehicles or at fixed sites. So, be mindful of not only what your enhanced 911 system does, but who would benefit from an enhanced 911 system. So these would be patients that are possibly confused, or a stroke patient, or a child, someone that can't tell you where they are. Like either they can't physically talk, maybe because they had a stroke, maybe they're confused because their blood sugar is low, or a child that doesn't know where they're at and don't know their location. This enhanced 911 system can help that because it can actually pinpoint the location if the caller stays on long enough to where they don't have to know where they are to find them. All right, communicating with the receiving facility. Why is it important? The receiving hospital will need as much pertinent information about the patient as possible. They may need time to set up special equipment or assign a special room for your patient depending on the present illness or mechanism of injury. So when calling in a report to the hospital, be sure to include the information you see on this slide. So your unit's identification number, you can give your name as well, but you cannot give the patient's name. So you can call, I can be like, hey, my name is Tamara on unit 34. I'm coming in with a 56-year-old male complaining of shortness of breath. Patient has a history of COPD. Give a baseline set of vitals, basically say how I treated this patient, how's the patient doing now, and I'll see you in, 5 minutes. That would be a good radio call. So I never gave any of the patient's personal information, anything that, you don't want to say anything that can be identified. So the patient's address, the patient's name, that type of stuff, you don't want to repeat over the radio for it to be identified by someone else. The oral report should summarize what you called in over the radio, chief complaint, vitals, treatment, and pertinent history. So it's basically, once you get there, you're just repeating to the actual, because when you call It's not going to be your specific nurse that answers that phone. Um, that may be just a charge nurse, that's just answering the phone or delegating which room these patients are going to. She may not be the person that's actually treating your patient. So once you get there and in that hospital room, you'll be able to tell them. You're basically going to give the exact same report all over again, but actually to the person that's treating your patient, or well, that's taking over care from you. Verbal and nonverbal communication. So remember we talked about tone and body language. So you don't want to stand over somebody with your arms crossed. That can kind of make them feel inferior, make them feel like you're not truly concerned about them. That maybe you're bothering them. Well, they're bothering you. So you always want to try to get down to eye level with them, make eye contact while you're talking to them. You can use hand gestures, um, provide comfort measures. Like if you want to, like you can put your hand on their shoulder. That's enough comfort measure for them to understand. Like, hey, you're there. You actually care about what they're telling you, what's going on. Be an active listener. Don't cut them off. Um, if you need clarification with something, explain like, hey, I didn't understand when you said this, and this, or I felt like you said this was hurting you, but is it because of this or whatever? Like, if you need to clarify, but just let them know that it's not because you weren't listening. All right, so these pictures are just showing what's the proper way and what's the improper way of communicating. All right, and then we get to the last chapter, chapter 6, which is lifting and moving. So you want to make sure you are using proper body techniques when you are. So we always prioritize the patient's ABCs, but when the scene of an accident is unstable or threatening to your life and the patient's, your priorities change. You must move the patients first in these situations. For instance, fire or potential for exposure or explosion, you would do an emergency move. What if the patient is in cardiac arrest and you do not have room to provide adequate CPR? That would be considered an emergency move as well. So you will make an emergency move only when no other options are available. Um, Examples of emergency moves would be your armpit, forearm drag, your shirt drag, blanket drag. You also can go into your urgent moves, including self extrication and rapid extrication. So, self extrication would be if a patient was blocking you from a critically injured patient and they're able to move out of the vehicle on their own. That would be an urgent move. Rapid extrication should be used when a patient has an abnormality of the airway, breathing, oxygen, or circulation. For example, a motor vehicle accident and the patient has altered status, major bleeding, or shock. Non-urgent moves is where there's no immediate life threat. If the patient can walk to the stretcher, assist them. Sometimes you will have to lift and move the patient. Some examples of these are the extremity lift, direct ground lift, direct carry, or draw sheet method. And your last one is going to be your two-person carry. So one EMT at the head, one EMT at the feet. The stronger EMT should always be at the head and face each other. The EMT at the foot is walking backwards. The four-person carry, one at the head. The EMT at the foot will be facing forward with his or her hands behind the body to grasp the carrying device. The other two rescuers will be at each side facing forward. All rescuers will be facing forward in a diamond shape. So if there are stairs, we're not rolling the stretcher up or down some stairs. What you can do is use a stair chair. This is the best device to move a patient up or down stairs as long as the patient's condition allows it. So if the patient must be supine one EMT is placed at the end of the head of the device facing the patient, and the other is at the foot end facing the patient with his back to the stairs. If a spotter is available, please use a spotter. Since the bottom, the EMT at the feet is going to be turned backwards, so they're walking backwards down these stairs with a patient. So if there is a spotter, you want to make sure you're using one. And that is it for Module 1.